Good evening, everyone, and a warm welcome to our patient education webinar. I'm really glad you could join us this evening to gain some new knowledge. We do have a short program lined up for you this evening. I'll start off with what's new about IBD in the COVID-19 era. For the sake of people who may not know me, I'm Dr. Huang. I'm one of the consultant pediatric gastroenterologists with NUH. My main clinical interest is in inflammatory bowel disease as well as gastrointestinal endoscopy. And I did part of my advanced training in inflammatory bowel disease at the Hospital for Sick Children in Toronto, Canada. And with me this evening, I have a team of very capable ladies who have also completed their attachment in pediatric IBD recently at two major centers in Boston and Toronto. They are Sister Pamela, who is our pediatric GI nurse clinician. We have Miss Wong Ying, our pediatric dietitian. And last but not least, we have Miss Hwei, who is our pediatric psychologist. We do have a short question and answer session at the end of this whole program. So without further ado, I will start off with what's new about IBD in the COVID-19 era. And first and foremost, I would like to just start the ball rolling by covering some basic stuff and which may be useful for people who are just recently diagnosed with IBD. So what is IBD in the first place? We all know what the immune system is, especially in the COVID-19 era, right? So we know about the immune system generating antibodies to protect us against viruses like COVID-19, bacteria, but the immune system does much more. It is basically like a policeman who protects us against, foreign invaders. It even helps us to fight cancer-causing cells. And did you know that 70% of your immune system actually lies in your gut, in your digestive system, right? And as I said, if you think your immune system as a form of law enforcement or policeman, there can be good cops and bad cops. A good cop is someone that would help to protect the innocent while using the appropriate amount of force to get rid of criminals, i.e. the bad guys, right? And while doing so, they do not harm the innocent while eliminating the bad guys. However, bad cops, on the other hand, they can't really differentiate between who's good and who is bad. Bad cops use an indiscriminate amount of force to eliminate what they perceive as criminals or harmful individuals when these individuals may actually be relatively harmless. So that encapsulates what exactly IBD is. It is really a result of an overactive, over-triggered immune system that is triggered by something that's relatively harmless. It could be a mild infection of the GI tract, a relatively harmless bacterial strain that is in the digestive system, and that sets off a vicious cycle of chronic inflammation that causes all the damage that we know in inflammatory bowel disease. So the end result of that inflammation is the two types of IBD that we know. One is ulcerative colitis, in which, as the name implies, this is a condition that affects only the large intestine, i.e. the colon, versus the other type, Crohn's disease, which was named after Dr. Crohn himself. And this is a condition, unlike ulcerative colitis, that can affect any part of the digestive tract from the mouth all the way to the anus. Another important point about these two conditions, in ulcerative colitis, this is a superficial inflammation that affects the topmost layers of the intestine, something like a sunburn of the colon, compared to Crohn's disease, where it is actually a deep inflammation that affects all 5 layers of the bowel. And especially in Crohn's disease, because it can affect any part of the digestive tract, you can get anything from mouth ulcers all the way to perianal disease, fistulas in the perianal region, and you get painful bruise-like marks that are affecting the lower limbs predominantly, and we call that erythema nodosum. Whatever the end result is, be it ulcerative colitis or Crohn's disease, the end result is that you get ulcers in the intestine from what is clearly a normal looking intestine in the picture above. And certain trends that you may want to be aware of from our Asian registry network, for which we thank some of you for contributing your data. We see that over the past decade or so, we do see a rapid rise in incidence. And this blue bar here actually represents Crohn's disease. And Crohn's disease is by far the most common type of inflammatory bowel disease you will get as a kid in a Southeast Asian network that we have. And interestingly, among the multi-ethnic populations in Singapore and Malaysia, we see that 33% of our IBD cohort are actually of Indian or South Asian ethnicity. This is clearly an overrepresentation because in our population census, only 7 to 9% are Indians or South Asian. This hints at some genetic predisposition towards IBD amongst the Indian and South Asian ethnic group. And besides genetics, are there any other postulated factors? Well, we think maybe our children are eating way too much processed foods. We see that there are emulsifiers, stabilizers in most of the foods that children like to eat. It's possibly due to the rapid urbanization. You know, this is Singapore in 2000, and now look at Singapore right now, 20 years on. And I cannot talk about IBD without mentioning the hygiene hypothesis. Many people think that our immune system is getting more and more, hyperactive or overactive, as I mentioned earlier, because we are exposed to less and less dirt, bacteria, and pathogens in the environment. When the environment becomes very clean and overly hygienic, then there is a theory that, when our immune system encounters even relatively harmless bacteria, it can actually respond very inappropriately with, that kind of inflammatory response you see in IBD. So that is called the hygiene hypothesis. Another interesting aspect that we see in our data is that amongst the Singaporean and Malaysian IBD patients, we see that Indians and South Asian with Crohn's disease are most likely to present with perianal fistulas. And what are perianal fistulas? If you follow my pointer, looking at a cross-section of someone's bum, a perianal fistula is something like a earthworm tunnel that burrows itself through the wall of the intestine, through the muscle, fat, and all the way out to the skin. And clearly this is something that is bound to be infected because the intestine is full of bacteria and it can discharge out pus and cause awful lots of pain and uncomfortable symptoms to the patient. We are clearly not alone in this trend. If we look at our North American colleagues, we also note that South Asian patients over there with inflammatory bowel disease are much more likely to have perianal fistulizing behavior right from the start. And this is what we actually see when we have a look at a patient's bum with a perianal disease. You can either have an awful looking abscess, that's the photo on your left, and these fistula openings, which I circled on the right, demonstrate what these so-called earthworm tunnels look like as they break out through the skin. So this is something really awful to have. And another trend that we are seeing is that very early onset IBD, or IBD that starts as 6 years or younger, accounts for a significant proportion of our Asian cohort, about 30%. And in certain places like Canada, actually children who are under the age of 5 or very early onset IBD represent the fastest growing age group in terms of overall IBD incidence. And this photo on the right just tells you how bad the colonic disease can be. This is in a child who is barely 7 months old, whom I looked after while in Toronto. And this suggests that genetics may be a likely cause as one of the factor driving this rise, but there may be more factors such as environmental exposures. And some of the frequently asked questions that I get in terms of the management of IBD, doctor, shouldn't we just treat the root cause of the problem, right? Maybe if I just change my lifestyle, I change my diet, my IBD may just disappear and I don't need any medications. The problem is that there is no one single cause that we know that causes IBD. Rather, it's a combination of multiple factors, and these causes may vary from patient to patient. It could be a combination of your own genetics, your lifestyle, your diet, inappropriate exposure to antibiotics when you were young, the use of medications such as NSAIDs, environmental pollution in a rapidly urbanizing environment, changes in your gut bacteria, but whatever it is, it may be a single factor, but more likely a combination of factors. This culminates in an overactive immune system being triggered, as mentioned earlier, and this results in an inflammatory response that causes damage into your intestine. And once the immune system is triggered, this is exactly like a bull in a china shop, right? So if you try to manage IBD with just lifestyle changes alone, without effective anti-inflammatory treatment, this is really like trying to close the door after the bull has already escaped, right? It is way too late. We first need to manage the damage that the bull has done. And that means calming the immune system to let the bowel heal. And the emphasis is that, especially in Crohn's disease, you need to treat IBD early before you have irreversible damage or scarring. This is because, as you can see with the red arrow over here, at the point of diagnosis of IBD, most patients have already accumulated a certain degree of digestive damage, and that is represented by the red line. The higher you get in terms of the red line, the more digestive damage you have accumulated. Fortunately, at this point of diagnosis, most of the damage is reversible with prompt treatment. But the longer you wait without effective treatment, you tend to get scarring, and scarring results in strictures. What are strictures? Let's look at some of the pictures on the right. So you first start off with a normal looking ileum, which is really the last part of the small intestine. But once you have scarring and once a stricture forms, this results in your normal looking ileum becoming a narrow, swollen hole. And obviously you are going to get symptoms from this. Food can't pass through, you're going to get symptoms of obstruction. You will inevitably need surgery at some point. So really, there is a window of opportunity for you to act early, to start effective treatment before you have irreversible damage, as you can see on the right. So it's really a two-pronged approach, right? So you want to control the bull and the damage that it has done with effective anti-inflammatory treatment. But of course, you want to try to prevent more bulls from escaping, right? So you address the inflammation, you try to heal the bowel, but of course, we try to advocate for certain lifestyle changes. You can't change your genetic, but maybe, right, there's some aspect of your diet that you can change, and perhaps that may avoid further triggers to an overactive immune system. And diet and complementary therapy can help in IBD, that's for sure. And the proof of that is that if we look at pediatric patients, i.e. our kids with Crohn's disease, just Crohn's disease and not ulcerative colitis, if we feed them an exclusive liquid diet with a formula for 6 to 8 weeks and not allowing these kids to take anything else, no solid foods, just a liquid formula, and maybe just some soups and plain water. This brings them back to the time when they were a baby just born out of a mom's womb, right? Just drinking formula or taking breast milk. No processed foods. This actually helped to induce healing in the intestine, which is highly effective. And it's just as effective as steroids, if not better. So there must be something about the diet that we can do to help to induce healing. right? And we know that there are natural anti-inflammatories around. So curcumin, which is found in turmeric, which is a common ingredient in lots of Indian curries, has been shown to help in colitis or large bowel inflammation. Vitamin D, which I emphasize a lot, this is one of the best natural anti-inflammatories, and it's not just important for bone health, it also helps to induce healing and to induce a state of anti-inflammation in our digestive system. And of course, we can talk about this later when Chui comes on board, but really there are certain foods that we think are pro-inflammatory. And of course, there are certain food groups that we think are more beneficial in inducing an anti-inflammatory state. So what's new? Well, I would say that in this current day and age, I think that personalized treatment for IBD is the way to go. Clearly, IBD treatment is not going to be a one-size-fits-all, as I've alluded to earlier. Every patient with IBD has his own unique genetics, his own unique environment. Even the disease is unique from person to person, from ethnic group to ethnic group. But the challenge is really for physicians and for patients, for parents alike, we need a better crystal ball. We need better predictive powers to predict who would do well with a certain therapy and who would do badly with a certain therapy. And of course, if our crystal ball becomes really good, we can just choose the right therapy right from the start. Sounds easy, right? But really, I think it's easier said than done. But we are a bit smarter in this day and age in 2022. There are certain pointers that indicate bad disease right from the start. If you have really bad and complex perianal disease, when I say complex, it means that when we do an MRI scan of your bum, we see multiple tunnels, the same kind of earthworm tunnels that you can imagine. If they are very complex and they are branching all around your bum, then this is really bad perianal disease, and this predicts a very bad outcome. If you have very bad large intestinal inflammation that results in these large and deep ulcers in your large intestine, again, that predicts a bad outcome without aggressive therapy. If you are way shorter than what we predict for your genetics, again, that predicts a bad outcome. And of course, if you don't even respond to the initial kind of treatment that we start for you, that again spells trouble. And we probably need to escalate your therapy to something much more aggressive and effective so that we can nip the problem in the bud as soon as possible. So what treatments can be effective, right? And really, I tell all the patients with IBD in Canada that the mission is remission. And what is remission? Some of you may have heard of the word remission in terms of cancer treatment, right? But really the term remission means not having any disease, right? Not having any symptoms. And what we like nowadays is to talk about deep remission, which means that you don't even have a trace of inflammation in your intestine when we put a scope in, when we check your stool test, or when we do a scan of you. Right? So there are two phases really. So one is to get you well, right? You are clearly unwell to begin with, right? You have tummy pain, you have diarrhea, you have bloody stools. We need to get you well, and that means getting you into remission. That is called the induction phase. Then thereafter, we go into the maintenance phase where we want to keep you well. We want to keep you in remission. And the combinations of these therapies really calm the immune system, and they treat the inflammation and heal the bowel. That's the end result of these two phases of treatment. So what are the individual medications and therapies we can do? So under induction, we have steroids, we have exclusive enteral nutrition, and we have biologics, right? You have heard of exclusive enteral nutrition earlier. Steroids are very effective anti-inflammatory medications, but they can't be used forever because they have long-term side effects such as growth retardation. So the trick is really to use a dose, the effective dose, to nip the inflammation in the bud and to reduce the dose quickly as appropriately so that the patient can be switched onto another medication to keep him or her well. And biologics are really the game changer in the management of IBD, and we'll talk more about that later. mesalazine or sulfasalazine, these group of medications, I like to think them as sunburn cream for the intestine. These medications are great for ulcerative colitis because they act on the superficial layer of the intestine. And clearly the next group is called the maintenance medications. So as I said, you can't take steroids forever, neither can you be on a liquid diet forever. So you need a second medication to keep you well. So you can either take azathioprine, which is an oral medication taken daily, or you can take methotrexate, which is an injection into the skin, and that is given once a week through the skin only. And of course, if you chose a biologic as your initial treatment, that as well can be your maintenance treatment to keep you well. And of course, your mesalazines and sulfasalazines can also be used as maintenance treatment, either alone or in combination with one of these medications. And I'd like to talk more about biologics because they are really the game changer in the management of IBD, and they are by far the most effective anti-inflammatory treatment that we have to date. So what are biologics? These are actually targeted therapies towards the pro-inflammatory proteins that your overactive immune system produces that causes all that damage. So if we know about antibodies that fight bacteria, that fight viruses, these are actually man-made antibodies. They are injected into your body. They come in just like policemen. They attack the main sources of inflammation, in this case called TNF, right? They eliminate the TNF, they eliminate the source of inflammation, and these antibodies are actually gobbled up by our own immune cells, so they don't stay in our body forever. So that's why we have to give you biologics on a regular basis in order for you to stay well. And because it's so targeted, meaning that it doesn't kill the rest of your immune cells that we require to actually prevent other kind of infections. So it is very safe and, of course, increasingly affordable because of the advent of biosimilars. These are copies of the original medication, but are just equally effective, and they are much, much cheaper. That means that we are able to offer biologic treatments to many more patients who were previously unable to afford it. And I must end off by saying that not everyone needs a biologic to stay well, right? You can get well on azathioprine or methotrexate, as I mentioned earlier. But if you have certain predictors of bad disease in some patients, they especially do need one, and they do need a biologic to be started as soon as possible to be effective. And how do we know whether treatment is effective? Firstly, as I mentioned earlier, there are different levels of remission. One is clinical remission, meaning that you must be symptom-free from IBD. You must feel well. You must have enough energy. You must be 100% on top of your game, and you have sufficient energy and motivation to enjoy all the things that you like in life. That's what we always want for all our patients. But going beyond symptomatic remission, right? Your gut must actually look well. So when I stick a scope in, we expect a gut that used to look like this from the beginning to actually heal. And that state is called mucosal healing, right? And that's really our target for all patients with IBD, that eventually we want your intestine to heal. And this is just a reminder that it is very important to test and to monitor for mucosal healing, because not having any symptoms does not mean you do not have any disease. And this patient is clearly a reminder of that. This is a adolescent girl who I managed with Crohn's disease, who had stopped her azathioprine for about 3 months because she was just feeling so fantastic. But one of the warning signs that she was having active disease because of her non-compliance was that her stool calprotectin result was very high. It was way higher than 1,000, right? And you can see why, because she had lots of ulcers, not just in her stomach, in her small intestine, as well as in the junction between her small intestine and her large intestine. So that's why I need your poop. And many of our colleagues in the GI division will also ask you for your poop, because your poop is the only way we can send off a test for calprotectin. This is a marvelous way for checking for internal inflammation without having to stick a scope in. And it is so convenient, right? So all you need to do is to bring your poop sample. You don't have to pop it into the refrigerator. It can be collected any time of the day. Of course, best first thing in the morning, and it can be left lying out in the open in a container for up to 1 day before you bring it back to the clinic. And of course, staying well in the COVID-19 era, I think this inevitably brings up the discussion about how safe are you? How safe are you on biologics with the virus going around? Well, the first thing first, having good IBD control is of paramount importance. Just being, symptom-free and being in deep remission, right, is protective of you from COVID-19. Right, so I emphasize that patients should not stop or delay your therapy, because poor control of your IBD itself is by far a big risk factor for a severe COVID infection. And being on a biologic does not put you at a higher risk of severe COVID. And we think one of the reasons why is because biologics are really good anti-inflammatory medications. And we do know that people who die of severe COVID actually die from the inflammation that is a result of having a severe COVID. And being on IBD may actually reduce the effectiveness of the vaccines, although we have even more data to actually demonstrate that the immune response isn't that bad anyway, right? But just to be on the safe side, we recommend for booster doses, not just for, people, the man on the street, but especially for people who are on some form of IBD treatment. And do not forget that there are other viruses that you may want to consider getting a regular vaccination. In fact, influenza is something that I highly recommend you getting an annual flu shot on a yearly basis. And not to actually forget basic hand hygiene and food hygiene, right? So if you are on IBD therapy, right, there is an increased risk of getting these kind of infections. So obviously, if you practice good hand hygiene, you practice good food hygiene, eating food that's properly cooked all the time, that will really protect you as well in the COVID-19 era. And staying well with IBD means so much more than just me as a gastroenterologist prescribing you medications, right? It is really about holistic care, right? That means the impact of this disease on you and your family, right? How does it mean for you as a child going to school, doing the things that you like, coping with work next time if you do part-time jobs as a teenager, and of course the cost of medication, right? We want to know all these because eventually you are our patient, not just the patient, not just your child, but as the entire family unit. So we want you to enjoy your hobbies. We want you to eat right, to eat healthily while still enjoying your food. We want you to travel, to enjoy life. And we also want you to actually transition to adulthood successfully, to go on to university, higher levels of education in a smooth fashion, right? So that's really about holistic and patient and family-centered care. And that's the importance of having a multidisciplinary team that I have today with us this evening. And they will give you advice how to eat well and how to feel well, right? So fatigue, depression, mood disorders are very common among IBD patients. And I want to emphasize that fatigue is a symptom not just seen in active disease because you have anemia and your blood levels are low. Sometimes it can be due to mood, sometimes it can be due to depression, right? But for factors we do not know, this is something that is very common in anyone with a chronic disease, not just IBD, right? So if it's something that's bothering you, I think this is something that we really want to address in our patients with IBD. And I cannot emphasize this more. but you are really not alone in this. If you go onto social media, if you go onto YouTube, you go onto Twitter, you're going to find many people who are living with Crohn's disease. And I do encourage you not to read the garbage that's on the internet, but to really look at these people who are willing to share their life stories as a form of support for yourself, to validate the same kind of problems that you must be facing, right? So these can be people from all over the world. They can be Asians, North Americans, and this guy over here is Japanese Prime Minister Shinzo Abe, right? So he's known to have ulcerative colitis, right? So it did cause some problem for him when he was in running for his second term, I believe. But this just lets you know that even people in the top guns, top seats, right, are also suffering from this condition. But life goes on, and many of them are successful individuals. And there are societies such as the Crohn's Colitis Society of Singapore, in the UK, in Canada, who actually have excellent representation, and they actually hold regular patient education workshops as well. I must say that this presentation is short. It's just the tip of the iceberg, and there are a lot of things that we do not know, and I hope to bring newer aspects of IBD in time to come, right? So what we do not know yet about IBD, right? We do not have a good crystal ball, as I mentioned earlier. We do not know who will fail standard treatment and who will even fail biologics. Remember, biologics are not 100% effective. And we hopefully one day that we have a blood test, a simple way of finding out who would tend to fail a certain type of therapy. And we can just choose the most effective therapy right from the start. Wouldn't that be great? And of course, many patients ask me this, and we still do not know a good answer when and how we can safely stop medications for good. But I must say that we don't even control your disease, i.e., we don't even get you into deep remission, then there can't be any discussion about stopping medication. So the first things first is to really to get you into a state of deep remission, i.e., not even a single ulcer in your intestine before we can even discuss about stopping medication. And of course, we all want a permanent, lasting cure for IBD without the need of medication, right? Isn't it great to be medication-free for life? That's something that we really want. And of course, lastly, what is the most ideal diet for IBD? And this is not one size fit all, because diets that are proposed by the Caucasian and North American population may not be suitable for the Asian population. This is something that really needs a lot more research in time to come. So I thank you very much for your kind attention. Yeah, and hopefully we have even more interesting talks from the speakers ahead.
Good evening, everybody. My name is Pamela. I'm the nurse clinician and also the pediatric IBD nurse. Today I'm going to talk about my role as your peds IBD nurse. I do patient counseling and also patient navigating. Essentially, my role as a patient advocate is to assist in being a bridge or point of care to your medical team or allied health. Example, your psychologists, dietitians, physiotherapists, occupational therapists, social worker. I am also your biologic navigator. So what does that mean? I will plan your admissions, monitor your levels, and also facilitate outpatient appointments and scans. So what information is important to me? I will be your point of contact. At the end of this presentation, I will give you my email and my patient hotline number. There are some common questions that I will ask during our text message or phone calls. So things like the current signs and symptoms, the current medication that you're taking, what is the common nutritional intake, and whether there was any infection exposure, example like the chickenpox, to measles, or even COVID-19. So when we talk about signs and symptoms, I could be asking you about whether your child has fever, pain, diarrhea, or how does the poop look like. So under the poop history, I will always refer the stools to a Bristol stool chart. As you can see on this chart, it varies from type 1 to type 7. When we discuss the poop history over the call or over text message, you could always refer to those numbers on this chart and let me know. And this chart is a clinical assessment tool that we use in many healthcare centers and is easily available on the web. If you would like a copy, I could always send them to you. So it tells us the shape and the consistency. So please feel free to tell me whether you're type 1 to 7. So what about medications? You might have questions about where to obtain your medicines, especially if the medications are new to you. Most of the drugs that we give would require a prescription from the doctor, and these drugs can only be collected at the hospital pharmacy. If you are on oral or subcutaneous injections, it can be taken home for administration. But if you are on biologic infusions, we will admit you to an inpatient ward or an outpatient facility. So there are various types of medications that you will be on. Some of you will be quite familiar with it. We have the 5-ASA, example cefazolazine, mesalazine, all known as Pentasa. You have your immunomodulators such as azathioprine, or you could be on steroids, which could be on prednisolone. You could be on antibiotics, biologics, as some of you are very familiar with, and also anterior nutrition. I will leave Ying, our dietitian, to elaborate on that later. Okay, so biologics injection, some of you will have seen this. These are our Amjevita pen and injector. The injector only comes in 20 milligrams and our pen comes in 40 milligrams. So these are some instructions that I would give to you when we start our initial administration. I do have a write-up or a hand-up. If you are interested, please let me know. I can always give you a copy. So these are the recommended sites for your injections. You don't have to worry, as the first few doses will be given in the hospital with me. We will introduce the sites to you face to face, and we can also discuss about which area you're more comfortable with. There are many methods in administration, but we can always explore. So this is a step-by-step guide, which is a printout, very nicely printed out in color. I have them with me, so if you are interested, the next time when you come to the hospital, I can always give you a copy. So zooming into this portion, talking about how the injection is given, sometimes we can use numbing cream, which will take about 15 to 30 minutes to react, or we do have some patients who have used ice packs to help ease the pain. So there are two methods, depends on how comfortable you are, which we can try. Number one is the stretch method, and number two is the pinch method. Some patients do find the stretch method much easier because you're administering it yourself. Some patients have also felt that the pinch method distracts them from the injection. But we'll see. Okay, so monitoring our symptoms during and after biologics, the symptoms can be quite similar. We can be looking at rash, hives, swollen face, hands, feet, trouble breathing, trouble swallowing, shortness of breath, lethargy, double vision, tingling sensation, numbness, sometimes cough, or maybe signs of infection. You can develop a fever, you're just feeling sick, or maybe some burning sensation when you pass urine. So monitoring your symptoms post-biologics at home, sometimes you can have abdominal pain, diarrhea, cough, pain, high blood pressure, rhinitis, hives, itchiness, fatigue, and headache. When you have any of these symptoms, please let me know so that we can determine whether you need to come back to the hospital again. So what are the precautions to take when you're on biologics? We would advise against live vaccinations, no exposure to infections, compliance to medications, follow-up of appointments is really important, frequent blood tests, and no smoking and drinking. So this is my contact, my email, and my hotline. Please do give me some time after office hours to reply. But if not, you can take a screenshot of this. Thank you.
Hi everyone, thank you for joining us today. I'm Chui, the Senior Dietitian from NUH. It is not always easy knowing what food best fuel your body, especially when you have IBD. With IBD, eating is always feel like a guessing game. So today we are going to answer the most frequent asked question of what should I eat when I have IBD? So what is the role of the diet in IBD? Nutrition affects not just the IBD symptoms, but also overall health and growth, especially for growing kids. Patients with IBD or carers are increasingly becoming interested in non-pharmacologic approaches to managing the disease. The role of the diet has become very important in the prevention and also the treatment of IBD. So here come back to the question, what should I eat? When we're considering IBD and diet, there are two different aspects. The first is to identify the pre-illness dietary patterns or habits that confer a risk to develop IBD, in which Western diet has been proposed as explanation for the increase in IBD incidence. And the second aspect is to identify the alimentary factors that impact on the inflammatory state of patients, so which link to the IBD specific diet. So many studies actually discuss a positive relationship between Western lifestyle and risk of developing IBD. So Western diet actually typically is actually high in sugar, low in fiber, and as well as high in fat, especially saturated fat, which may be causing a leaky gut with increased permeability and changes in microbiota. It's actually also high in omega-6 to omega-3 ratio because of over-reliance on vegetables oil, such as like corn oil, soybean oil, sunflower oil, which are commonly used in packaged and processed food. And we know that actually omega-6 fatty acids tend to be pro-inflammatory, whereas omega-3 has a strong anti-inflammatory effect. Western diet is actually also high in emulsifier. So those Western diet is actually rich in food or beverage that containing large amount of emulsifier. For example, like ice cream, sauces, chocolate, and fast food. And why is emulsifier bad? Because it actually can change the mucosa barrier directly or change the intestinal microbiota biodiversity. So all above that we have talked about is actually increase the risk of getting IBD. So for IBD specific diet, what is the diet best for IBD? A few popular diet have been promoted to reduce the intestinal inflammation. This include the CDED, Crohn disease exclusion diet, which we are currently practice in NUH. Other diet like anti-inflammatory diet, the IBD-8, the paleolithic diet, SCD, the specific carbohydrate diet, and low FODMAP diet. However, there is still lack of evidence that demonstrate which diet is the best for certain patients. At this time, we do not know what causes IBD. There's no specific diet that we can prescribe to cure IBD, but we focus on the nutrition and growth as part of our follow-up. We know that food and drinks affect individuals with IBD. Managing IBD symptoms with food and drinks is subjective and is different from person to person. We support any changes that help with symptom management. So everybody IBD is a little bit different. Your dietary recommendation should be tailored to your individual needs. But no matter what your IBD needs is, maintaining a diverse and nutrient-rich diet is the key when you are in remission. So here are something to consider. general healthy diet when you are in remission. So we advise that you eat a diet that is rich in vegetables and fruits. So when we are taking vegetables and fruits, we try to get different colors of vegetables, fruits, to actually, because fruits and vegetables is have content of different type of vitamins and minerals and fiber as well. We try to choose diet that is rich in whole foods instead of packaged and processed food, and to include a source of protein at each meal, and to increase the calories intake. So we always encourage the kids to have include their breakfast every day, because we understand that most of the kids actually skip their breakfast in the early morning, and this actually reduce the total calories intake. So as well as include some nutrient dense snacks to optimize their calorie intake for their growth. Here are some idea of the homemade nutrient dense snacks. So I included some option this because of we know that mostly when we talk about snacks, we are always thinking of like those maybe not so healthy food, like the junk food, or maybe like the you can bet it for the store-bought kind of like biscuits or bun that actually we consider as like a processed food. So actually we can actually do our own snack at home. So if you like some crispy crunchy stuff, we can do some homemade granola bars. So it's actually source of soluble fiber, like if you use like oats or banana, which can help to form the stool if you have loose stools or high outputs. To increase the calories, you can try to add some avocado and coconut fats. And if to reduce the added sugar to the recipe, we can actually use sweet fruits or honey to make it sweeten, and add some flavors like unsweetened cocoa powder, pasteurized honey, or cinnamon. So if you like nuts, you can do like homemade trail mix, include like some dried fruits, chocolate chips, and different nuts. And we know that nuts actually is high in protein. So fruits is good, and it's contain fiber and different vitamins and minerals, but we know that fruits is actually quite low in calories. So to actually increase the calories when you're taking fruits, right? So try to maybe can have some dips with it. For example, you can have some cheese that to add on the protein and to make it more creamy. Nut butters actually is also high in protein. It goes well with many kind of fruits. So if you prefer like not the hard or crunchy stuff, so we can have some soupy stuff like red beans or green bean soup. Beans are actually good source of protein and fiber, and to add up the calories, you can actually add some milk into it to increase the calories intake. So here to come to my last slide. Eating well for IBD is also healthy eating for all. Eating well is not temporary, but is a lifestyle change and commitment. So to involve family and friends, everyone can support each other to eat well. Let's do it together, and let's start now. Thank you.
Hello everyone, my name is Hwei, and I'm a psychologist with the Department of Pediatrics. One of the things that I do within the department is to see children and teenagers who have been diagnosed with IBD. Today, I hope to provide you with some information on how a psychologist can provide additional support for chronic medical conditions and why this is important. So first, who are psychologists? We are a group of people who specialize in the study of the human mind and behavior. We are involved in the treatment of mental, emotional, and behavioral issues. And because this is pediatrics, we focus on children and teenagers. Now, contrary to popular belief, psychologists cannot read your mind. We are just very good at listening and observing, and therefore tend to be able to quite accurately guess what you're thinking and feeling. Some of you may wonder if psychologists and psychiatrists are the same. Nope, we are not the same. Psychiatrists are medical doctors who are trained in mental health. Psychologists are not doctors, and we cannot give medicine. Rather, we listen and help you to better understand your difficulties, and then help you to come up with ways to problem solve. We usually teach skills as well, and these skills help you to solve or improve on the challenges that you face. Oh, And seeing a psychologist doesn't mean that there is something wrong with you. Most of us talk to someone when we are troubled, like a friend, a teacher, our parents. And psychologists are just very well trained to be good listeners. So, why would you need to see a psychologist when you have IBD, which is a medical condition? The IBD psychologist helps people to adjust to being diagnosed with and to live with a chronic medical condition. After being diagnosed with IBD, so many things change. Hospital visits, lifestyle, diet, mindset. And it helps to have someone to talk to about having to deal with all these changes. Compared to everyone else, people with IBD experience more anxiety and low mood. It can be up to 2 to 3 times more. Part of this is due to having to make many adjustments, but there is also this very special link between our stomach and the brain that makes mood changes more common. And this link is called the gut-brain axis. So for the gut-brain axis, right, we are concerned with the brain, the stomach, and then this other part known as the vagus nerve. Our brain has actually 100 billion neurons. Neurons receive information from the external environment and send and receive from within our body. The messages are sent through tiny chemicals called neurotransmitters. Neurotransmitters control feelings and emotions. For example, the neurotransmitter serotonin, it helps you to feel happy. Interestingly, many of the neurotransmitters are also produced by your gut. There are 500 million neurons in your gut. That's half as many as the brain's. And 90% of the serotonin is produced in the gut. So you can actually tell people that, it is your stomach and not the brain that helps you to feel happy. The gut also produces a neurotransmitter called GABA, or gamma aminobutyric acid. GABA helps control feelings of fear and anxiety. And then we have the vagus nerve. It helps to transmit information between the gut and the brain. So now we know why emotional and mental health are important for someone with a gastrointestinal issue. But why are we more concerned about the young people? All of us go through a period of adjustment when we receive life-changing news. Research studies consistently show that young people get more affected by a medical diagnosis compared to adults. And this is actually very normal if you think about it. Think about the life stages and the changes that the young people are in. Comparing, adults usually have established a place in life for themselves. They have a firmer sense of identity, occupation, or role that is well-rooted. Adults would also have more opportunities to learn and cope with adversity. Young people are just beginning their life adventures and do not have an established identity yet. In fact, the major task of being an adolescent is to kind of explore and kind of establish your identity. Neither do young people have as many success experiences to fall back on yet when they have setbacks. Also, adolescence is the time when we try to be more independent. And having to depend on and follow through with instructions from the healthcare system and family members during this time can be quite tough to accept. Some people may be curious, what are some of the top concerns that patients with IBD have? From 2014 to 2015, a group of researchers in Canada answered exactly that question. They asked what patients were most concerned about when they have to live with IBD. And over several in-depth interview sessions, patients were asked what their experience had been like and what problems they have experienced physically and emotionally. The responses were analyzed and 4 major areas came out. Number 1, awareness and understanding. People in general have poor awareness and understanding of IBD. Family and friends do not fully realize how painful and how tiring flares can be. For students, having to ask for and getting frequent permission to use the toilet was a huge problem. Attendance at school or at work is also a problem due to hospitalizations and clinic appointments. Does that sound familiar? These are some of the verbatim responses that the interviewees gave during the study. Psychologically, there is also the feeling that IBD is running the whole show and controlling their lives. What to eat, where the toilet is, how far I need to travel to get to a toilet, whether I may accidentally soil myself. These were questions at the back of one's mind, especially during flare periods and the initial recovery days. Having to deal with IBD daily on a long-term basis can take its toll. There is also the pain and persistent fatigue, as well as body consciousness to deal with. Longer term, people were concerned about medical costs. Young people feel guilty about their family spending so much money on treatment. They also worry if they will be able to earn enough money for their own medical bills one day. And lastly, the quality of care is a concern. Because IBD is not easily diagnosed, people have shared on the difficulties they experienced before getting their diagnosis. There were experiences of being called attention-seeking, for being overreactive, or there have been people who have been misdiagnosed. These experiences may cause initial distrust in the healthcare system and the type of care that is received. Now, a number of concerns here can be actually shared with the psychologist, and ways of dealing with these concerns can be addressed. By now, I hope that you have a clearer idea of what the psychologist does in an IBD clinic. And should you need to get access to a psychologist, how do you do it? Simple. Tell your doctor, or tell Pam, or tell Chui. They will be able to make the referral on your behalf. Remember, while looking after your physical health is very important, it is also important to look after your mental health. It is alright to reach out for help. It takes a wise person to recognize that he or she needs help, and a brave person to actually reach out to get that help. So be wise and be brave when you need to. With that, I thank you for your attention and welcome any comments or questions. Thank you.